The next presenter is Bob Achila. Bob Achila is a urogynaecologist.
So our topic is on transperineal ultrasound, which maybe to many people might be a new concept, and how we can integrate it possibly into our routine care of patients in the third trimester of pregnancy. You know, there's this concept of doing ultrasound in the third trimester, which is becoming quite popular in many countries. And in fact, in many hospitals, they have now introduced routine third trimester ultrasound. And like ISWOG is an international organization which is ultrasound based for OBGYN. And they have recently come up with guidelines on third trimester ultrasound. And you know, there can be some benefits of ultrasound in the third trimester, and I can see my friend Deepak is there, and he will agree that there can be quite some bit of benefits. But what bothers me more than anything else is that despite doing ultrasound in the third trimester, we are still getting surprised in the labor ward in terms of a patient you've been seeing since 8 weeks of pregnancy, and you're rushing at 2 a.m. to do an emergency cesarean section. This seems like quite a strange situation to anybody outside of obstetrics. Why are we not able to know that this patient will not be able to deliver vaginally? Then, problems like prolonged duration of the second stage, which we know, of course, can have many issues in terms of morbidity, neonatal ICU admission, and other kinds of complications. And then the other issue is trauma, third-degree tears, fourth-degree tears, or even worse. You have to know that also ISWOG says that as much as we're doing ultrasound in the third trimester, it's not routinely recommended. There are so many limitations to these kinds of ultrasound because visibility is very poor, weight estimates are not so good, and there are some changes which you might see, for example, in dopplers, which are difficult to interpret, and then sometimes can lead to over-intervention. So yes, we are doing ultrasound in the third trimester of pregnancy increasingly, but I think the question is it really helping us? But also, can we do better? Are there other things we can introduce into that ultrasound to benefit our patients? Because we are still facing challenges in our country. Maternal mortality, neonatal ICU admission, and birth trauma. This is what I was talking about, Kimani, where at 2 a.m. you are rushing with your patient to do an emergency cesarean section. Why can't we predict in advance that this patient will not be able to deliver vaginally? In this era of AI and so much technology, what's going on? And then trauma. Your patient he has like you can see here, this is like almost game over here. When you're seeing fat like this, it already means that levator ana is already torn, and this one maybe we don't have any way of repairing these kinds of tears. And then fistula and fourth degree tears, dyspareunia. I mean, these are life-changing injuries to our patients. My student Kimani say something. I think sometimes in medicine we are not thinking about the patient. Patient is under anesthesia, but we are engaging in other issues in terms of creating artificial boundaries. And yet the main focus should be how do we assist the patient. Like you can see, if we keep on having these kinds of discussions and not focusing in terms of what is the problem and how can we solve it, then the person who apparently is supposed to do what he says he should do sometimes can end up getting overwhelmed. Like you can see here, the injury is still not repaired. And the person who said he's the one to do it now is completely overwhelmed. The guy who's up there is actually the gynaecologist, and this other person is the colorectal surgeon. And you know, sometimes there can be those kinds of fights between different cadres. I don't think this is very useful to us. So you can do training, I'm not saying that you have to do training to this kind of an extent in terms of pelvic floor imaging and fetal imaging, but I think the more knowledge you acquire, the more you start getting ideas in terms of maybe what you are doing in 2026 might not be the ideal for our patients. And of course, also with more training, then you realize the importance of possibility of collaboration. Like here, instead of colorectal and gynaecologist fighting, maybe there should be collaboration in terms of competence and training and and then of course even fetal medicine and either gynecology or urogynecology. I think for the benefit, the main focus should be on the patient. How can we help the patient? Because definitely we still have a lot of problems in terms of how we are taking care of our mothers. And I think ultrasound can be a very powerful tool for collaboration between these various cadres in terms of evidence, the best treatment, and possibility of follow-up. Look at this image. Look at this image. This is from the year 1800. The year 1800, there's a gynecologist who's examining a patient, and I mean, of course, maybe there's the idea of modesty, and then maybe just using this is like what is it called? Palpation only, to be able to make a diagnosis in the year 1800. Okay, this maybe laughing at this, but how are we managing our obstetric patients? Is it any different? Any difference? Like somebody will say, the patient is 6 centimeters dilated. I don't believe it. Or I think the funniest is the effacement is 60%. Maybe fake. I mean, is any of this really reproducible? That the gestation is +2. I'm just wondering. These are things which bother me quite a lot. I don't know what your opinion is about this kind of management. Is it any different from 1800? The way you manage our patients who are in labor? I mean, I'm not saying it might be wrong, but we're just trying to think whether this is how we should be managing patients in the year 2026. Because there can be better tools, including use of ultrasound. Like here we're talking about transperineal ultrasound, where you're able to, I don't know whether there's a pointer. Is this one showing? Okay, but anyway, the blue is just representing the fetal head. You place the ultrasound probe transperineally, and then you can be able to take various measurements in terms of descent and to monitor labor progress. And that is the pelvic floor muscle in an axial plane, where you can be able to see the puborectalis muscle. And this is the hiatal circumference. That is where the baby's head is supposed to, that is the portal through which the baby will be delivered. Of course, obstetrics has undergone quite some bit of transformation, because previously this concept of CPD was well recognized, but it was mainly based on the bony structure of the mother versus the baby. But now the thinking is, which you're trying to champion, that maybe the barrier is not the bony structure, but possibly what is appearing there in terms of the white. That is what the baby has to be able to pass, and sometimes can result in prolonged labor, emergency cesarean section, or because the baby is just too big, resulting in birth trauma. This is the concept that we are thinking of, because it's just that old concept of passage and passenger. And then maybe what can we use as a measure of the size of the passenger, which could be the head circumference, because we're already doing ultrasound in 3rd trimester, and I have my own doubts about its utility. But why can't we take one of the measures which we use, which is biometry and head circumference, and use it as a measure of the size of the baby? And then, now not measuring the distance between the spines and all those things that we used to check, but possibly checking the hiatal circumference or area as a marker of the passage. And then now, based on that, be able to try and come up with a prediction of expected labor outcome. because our enemies are emergency cesarean section. It's not a good outcome. The patient is not happy, you're not happy, but you should have known, or at least that is what patients expect from us. Instrumental delivery and emergency cesarean section. So the idea behind this kind of a research is to ask the question, can the relationship between the fetal head size and levator hiatus size predict the mode of delivery? And there are some parameters which we propose for doing this study. And then you can always be able to use maybe this kind of relationship between the fetal head circumference, which is quite easy to do, and the hiatus circumference. We'll go very quickly because of time, maybe in terms of trying to explain this concept of transperineal ultrasound. It's not something which is quite new. It has been there since the 80s. But unlike laparoscopic suturing, this is very, very easy. You can do it. Once I finish with this lecture, I want you to do it from tomorrow. And the images can be quite very nice depending on your machine. And in fact, we believe that this can be better than MRI in terms of soft tissue discrimination. And there are many, many indications. We're using it quite a lot in urogynaecology, almost routinely for all kinds of issues. And maybe at a later talk or another time, we can discuss the indications for translabial ultrasound. Translabial ultrasound is the same as transperineal ultrasound. You can also call it pelvic floor ultrasound. It doesn't really matter much. This is not a very advanced machine, as you can see. And then you have the normal probe that you're using for obstetric ultrasound, for those who do obstetric ultrasound. And then you have to know where the probe marker is in terms of orienting yourself. And then ultrasound gel. And then glove. Okay, not sterile glove, because it's outside, it's on the outside. You don't need sterile, no need for you to stress too much. And then apply gel on the top and you're ready to go. You can do it. But sometimes, of course, if you really want to be a bit more advanced, then you have to use a better machine with the capability for 3D, which will be a different kind of a probe, especially if you want to have an axial view and look at the levator ani muscle and things like that. And then this is how you basically do it. You place the probe transperineally. And then that cartoon is showing in an unpregnant woman what you'll be able to see. You can see there's anterior, where you can see the pubic symphysis, and posteriorly, oh, but I need the, no pointer.
It's on the, you can't touch screen.
But I'm trying, I have to teach. Can you see? Okay, but anyway, posteriorly is the levator ani muscle. And then there's the anal canal, which becomes the rectum. And then you can see the bladder anteriorly and the urethra, and then there's the vagina and the uterus. Okay, so once you place the probe transperineally, so long as your probe marker is okay, which I told you about, then you're able to see the structures quite clearly. So that is a pubic symphysis, that is a urethra, that is the levator ani muscle, that is the vagina, uterus, that is the anal canal and rectum, and the endometrium, and that's the bladder. Very, very easy, okay? Video just showing, because you're moving from, we are spanning from side to side, and you can be able to see the uterus in the middle, okay? Today I'm not giving a talk on transperineal ultrasound as such, but concentrating mainly on its use in pregnancy. But of course, if you have an anterior vaginal wall mass, or if you have prolapse, or any issue happening to do with urogynecology or general gynecology, I think this can be a very powerful tool for you to be able to make a diagnosis. So we'll because of time, we'll just concentrate on ultrasound in labor and delivery and in pregnancy, concentrating on those key issues which we said are a problem in modern obstetrics. We are getting surprised in the labor whether the patient has a 4th-degree tear. We are rushing the patient for emergency cesarean section, and patients are ending up with a lot of morbidity, and yet maybe there could be some form of predictive model. This is what we said. Same technique. Same technique, place the probe transperineally. You're able to see the fetal head. And there's this concept of angle of projection, which means you are taking the angle if you take a plane through the pubic symphysis, its longest plane, and then the other one is to the baby's calvarium, and then that angle, let's say this is like 90 degrees, and you can tell immediately if there's more descent, the angle will keep on increasing, which means something like 135-degree angle is better than 90-degree angle. This is definitely much more objective than what our interns are telling us of station +1, which is, I think, fake, most likely. Yeah? And then there are other measures which you can use also, like head-perineal distance. I think this is quite easy. Anybody can do it, and then you don't need an advanced machine. I think we can modernize obstetrics. This is the reason why we have come to Central Branch, to champion for the modernization of obstetrics. So this is just another image which is just showing, I don't have a pointer, where the baby's head might be. Of course, this head is quite low, which means, for example, don't even think about doing an instrumental delivery for this patient. You will not succeed. Morbidity, time wasting. This patient, if there's a problem, maybe better to have a cesarean section, I think. As we come to the end, there's this concept of trauma, okay, birth trauma. Maybe for most OBGYN, once the patient has gotten to this stage, everybody is completely relaxed. Maybe nothing can go wrong. Maybe the only thing is, maybe shoulder dystocia or PPH, but otherwise everything should be okay. But a lot of things are actually going wrong. It's only that maybe in our training, we always look on the outside in terms of first degree, second degree, third degree, fourth degree perineal type, but we don't think about the inside, which is the pelvic floor, and the damage that is occurring. Look at this. This is the pelvic floor muscle, and it is undergoing a tremendous stretch. This is completely unbelievable. That a skeletal muscle can be stretched this much, and then we always think that everything is okay, because every muscle has biomechanical properties, and when you stretch a muscle to this extent, okay, usually there's some damage which happens to it, and maybe unfortunately sometimes maybe no recovery, but we are not taught and we never think about it, and sometimes we don't have the proper tools to be able to make these kinds of diagnoses. Oh, sorry, the blue. Oh, sorry, go back. The blue was the baby's head. I don't know whether you got it. The blue is the baby's head. That brown is a anal canal. And then image 1 is showing at rest, and then maybe when everybody is completely relaxed, baby is about to be delivered, but that is the most dangerous time in terms of the pelvic floor muscle, in terms of maybe the stretch is now too much, or, and I'll show you a video of what sometimes happens. Baby is coming out, and baby has been delivered. Everybody is completely happy, but look at the muscle. What has happened to it? What has happened to the muscle on the right side? Not stretched. Something more has happened. Okay, stretch is one issue, and then the muscle will always be ballooning in future. But for the baby's head to be delivered, what has happened on that side, on the right side? Yeah, it has detached from its attachment to the pubic ramus. And then now, at least in urogynecology, now we know that maybe this is the injury which is occult, which later results in other problems in future for the patient once they are now in their 50s, 60s, postmenopausal. These kinds of occult injury actually maybe might be the hidden thing which now results in things like prolapse and incontinence. And then sometimes we do surgery for prolapse, and then the patient quickly gets a recurrence. But it's usually because the damage is quite extensive, and maybe no simple surgery like anterior colporaphy can help. Maybe you need to think of doing something a bit better, but you can only do that if you are able to assess the patient properly. So using 3D technology, you're able to see this is intact muscle, and this one is showing some detachment. At least from that first image on the right, there's injury to the levator ani muscle. At least on that first image. So if this patient had a prolapse, I would be a bit careful in terms of what is the best treatment option for this kind of a patient. So we are just closing, and this is just to re-emphasize on this idea that we are thinking of in terms of we are already doing a lot of third trimester ultrasound. Its utility is in doubt, but we don't want to throw it out. I think we can improve it because the challenges are still persisting. The challenges of morbidity and mortality are still persisting. And then why can't we now add more value to third trimester ultrasound and maybe combine something like the fetal head circumference and the hiatal circumference or area and come up with a ratio, and then now follow up the patients and be able to come up with a good study to tell us whether this can work or not. Thank you.